Why treating strictly from an image is bad medicine. Hey folks, this is Dr. Jeff Williams with Creekstone Integrated Care right here in beautiful Amarillo, Texas. And I'm coming to you again this week with a new video. And here I'm talking about treating patients from an image like an X-ray or an MRI rather than treating the patient that is sitting directly in front of us. And what impact that can make on the patient. It can be pretty big. First, what exactly does it mean to treat from an image? Well, let me explain. When we say treat from an image, we're referring to an old and archaic, outdated tendency to shoot X-rays or get an MRI immediately for a patient that's suffering pain before doing anything else, and then using that image to diagnose the patient and to treat that patient. Many practitioners that are stuck in the past, they have a lazy habit of treating patients like this. It's essentially treating from an image rather than treating based on the patient that's sitting right here in front of the doctor. Now, the first thing to understand about this and why it's such a bad idea is that many of the things that are found on X-rays and MRIs, they're absolutely normal and are not necessarily what is actually causing the pain a patient is having. Many times, if they are the culprit causing the pain, the doctor is not properly educated on the current guides and research on exactly the best course of action to take for treating that particular issue. For example, a large herniation that's not really causing any weakness in the legs and it doesn't really alter any bowel or bladder function, the larger the herniation, the more likely it's going to be recognized as being foreign by the body and to be absorbed by the body sometime in the near future. Now, a practitioner that's not up on the current research would assume that it just needs to be surgically removed. That's not good. Now, to explain just a little better, let's assume an MRI shows us that there is a disc herniation in the low back and that the patient's having some generalized back pain. And it hurts when they lean backward, especially when they lean back and turn to the right or to the left. Many practitioners would commonly order an MRI right off the bat if they felt it was severe enough. Now, let's assume the MRI comes back, it shows a disc herniation. Well, the next common step would be to recommend the patient to go to an orthopedic surgeon or maybe a neurosurgeon, potentially even a pain management doc. In all of these cases, they'd probably get shots and potentially even surgery. Now, in this particular case, we know through research that if a patient is between the ages of 40 and 50 years old, they have absolutely zero pain at all. If we get MRIs on them for research purposes, 60% of 40 to 50-year-olds will have age-related findings. Age-related findings like herniated discs, disc bulges, annular tears, facet hypertrophy, degenerated discs, and things of that nature. But it's all absolutely normal, all of it. And these patients have zero pain. All of these things cause no pain whatsoever, typically. So 30 to 40-year-olds, for example, they're more in the 40 to 50% range for age-related findings. But let's go higher, older, 60, 70-year-olds. Those folks are 70 to 90%. You're going to find age-related findings. Even about 30% of 20 to 30-year-olds have significant findings on MRIs that do not mean a thing in the world other than the fact that they are normal human beings. So my point here is something will be found on X-rays and MRIs, but does that mean that that something is the culprit? Well, the probability is actually pretty low, and that's based on solid research. Certainly, the older the person gets, the less likely what you find on an X-ray or an MRI is the actual culprit. So let's pick this patient apart a little bit further, okay? When pain is caused by extending at the back or at the waist and then rotating one side or the other while extended at the waist, well, that is highly suggestive of what is called facet joint pain. When we combine that information with generalized pain that's hard to localize and the fact that that pain can be caused when I poke over the facet joint area, well, it sure sounds like a facet joint is causing the pain rather than any sort of disc herniation, doesn't it? This stuff can usually be snuffed out and figured out when a competent practitioner performs a proper orthopedic and neurologic exam and finds no hints that it might be a disc herniation. Well, this patient, when properly routed, can be treated very effectively by a patient-centered, evidence-based chiropractor. And not only can they be treated effectively, but they can be treated typically in only a handful of visits, because facet pain responds very well to movement-related treatment like chiropractic. However, if we have a less educated and or maybe potentially a lazy practitioner as the initial point of contact or the first doctor this person goes to see, then they might get an MRI right off the bat instead of a competent physical exam. And there's an excellent chance that the disc herniation is confused as being the actual culprit strictly based off of the MRI findings. And now the patient's going down the path of medication, steroid shots, and potentially surgery to fix a disc herniation that is probably not even the reason the patient is in pain in the first place. Now, what this is called through the research is called escalation of care. And that means the patient got significant treatment that they did not need because the practitioner did not do their due diligence in assessing the patient clinically with a good exam. Instead, care was escalated to an unnecessary extent just because they found stuff on the MRI. Stuff that we all have when we get older. Stuff that's absolutely normal and stuff that is usually painless. Here's a real-world example for you. I had a patient in my clinic just last week that was suffering from knee problems. Well, one knee problem, his left knee. This patient had gone to their medical doctor first. Now, this doctor had this patient convinced that they needed knee replacement surgery because they took an x-ray and there was some degeneration present. This was an orthopedic doctor, by the way. In fact, this orthopedic doctor told them that it was bone on bone in his knee. The only reason the patient was here in my clinic was that he was too young to have knee replacement surgery just yet, and he wanted to see if there was some way we could get the inflammation to settle down and make it feel better until he was old enough to get that inevitable knee surgery. Now, that all sounds good, except for the fact that based on a competent orthopedic knee exam and not based on an x-ray image, the patient had zero signs of pain coming from the cartilage in the knee joint, or lack of cartilage, if you will. He did, however, have signs of pain that are commonly caused by a strain of the medial collateral ligament on the knee. Now, understand that this patient had already been prescribed pain pills, already underwent steroid shots before they even got to my office. Now, when we identified what is clinically causing the problem with the pain by actually laying fingers and hands on this person, we were able to recommend focused and conservative treatment that has this patient on the path to feeling better and hopefully avoiding any future inevitable surgery. He was able to be treated non-pharmacologically, safely, and conservatively. It just isn't hard to see the incredible value in treating patients in this manner. I want to provide you real-world research demonstrating the dangers of treating imaging rather than treating the patient sitting in front of us. The research was done in 2012 on the percentage of patients that wind up having surgery depending on what kind of practitioner they treated with first. They were able in this research paper to demonstrate that 42.7% of injured workers that treated with surgeons first, 42.7% of injured workers treating with surgeons first ended up having surgery. That's almost half of injured workers had surgery when they treated with a surgeon first. On the other hand, only 1.5% of injured workers in this project who saw the chiropractor first. The doctor of chiropractor was the first point of contact. Only 1.5% of these injured workers ended up having surgery. 1.5% versus 42.7%. To me, that looks a whole lot like go see a chiropractor if you want to avoid surgery after hurting yourself. Now, the research project was done by Keeney et al., and it shows impressive fashion how your choice of practitioners can affect the entire remainder of your life and the quality of it. It's vital. When you look at this on paper, it's impressive. It's impactful. But the impact is more significant, much more significant, and goes much deeper if you consider that back surgeries cost around $65,000 to well over $100,000. Beyond the cost is the recovery period. It's significant for the patient and the caretakers in the home for the patient. I think one should also factor in the fact that so many spinal surgeries are either failures or have to be repeated at additional cost, additional recovery, and additional stress and strain on the employee and the employer alike, or just a regular patient. You don't have to be injured on the job, just in your everyday life. This is big stuff. All of this when the patient, in so many cases, did not usually need surgery in the first place. It drives me crazy if you can't tell. For all of these reasons, current guidelines suggest to practitioners that they should pump the brakes on ordering x-rays and MRIs all the time as first knee-jerk reactions to assessing pain in their patients. That doesn't mean people don't need x-rays and MRIs. They absolutely do. These are vital tools to helping us diagnose patients accurately, but they're usually not needed in the beginning. There are what is called red flags that should help guide practitioners on when exactly imaging should be ordered. Common red flags that can trigger imaging like x-rays and MRIs are as follows. Pain in patients younger than 20 and older than 50. Traumatic onset, which means like pain caused by an accident of some sort, car wrecks, falling off a ladder, bumping your head, things like that. History of cancer. Night pain, especially unrelenting night pain that wakes you up. Fevers, unexplained weight loss, pain at rest, like as in you just cannot find a comfortable position that relieves it. Immune suppression, recent infection, generalized systemic diseases like diabetes. Failure of 4 weeks of conservative care, meaning you went to the chiropractor, you went to the PT or whatever for 4 weeks of conservative care there with no relief. Well, then x-rays may be, or MRI might be warranted. Then there's Cauda-Equina syndrome, which it shows itself when bowel or bladder function is altered, or when there are pins and needles in the areas of the body kind of down and underneath that would touch and sit on a saddle. And the last red flag is motor weakness in the lower limbs. So while that leaves plenty of reasons to still get imaging, not included on that list is because it hurts. But because it hurts seems to be reason enough to have imaging for many healthcare practitioners out there. Current research and guidelines say that this mentality has to change now. The American College of Physicians now suggests seeing a practitioner that can perform spinal manipulation, soft tissue therapy, exercise, and acupuncture first for back pain. That's first, in case you didn't hear that, before ever considering pharmaceuticals, shots, surgery, any of that stuff. Now, those therapies accurately describe an evidence-based, patient-centered chiropractor. If you're from the Amarillo, Texas area or traveling through and you need a second opinion or you just need to be evaluated and treated, call us at 806-355-3000. Let's get you on our schedule. If you're watching this on YouTube, hit that subscribe button. You don't want to miss our weekly, highly valuable videos. If you're watching on Facebook here, hit that like button and then share with your friends and family. I promise, even if this information isn't necessarily important for you personally right now, it will speak directly to someone in your network of family and friends. I promise. Again, I'm Dr. Jeff Williams, chiropractic orthopedic specialist with Creekstone right here in Amarillo. Until next week, stay safe, stay smart, and we'll see you then.